Welcome back. This is Daybreak, and thank you for staying with us. The hashtag on X is Daybreak. The SMS code is 22422 at Citizen TV Kenya, and at Ayub Abdikadir. Dr. Davji Atela is the Secretary General of the Kenya Medical Practitioners and Dentists Union, KMPDU. Dr. Robert Pukose is the lawmaker representing Endebess constituency, and as well the chairperson of the Health Committee of the National Assembly. Gentlemen, thanks for staying with us. Shortly, we'll be having Dr. Brian Lishenga, who is the chairperson of the Rural Private Hospitals Association here in the country. Let's have this soundbite, Dr. Davji and Dr. Pukose. This is the Health Cabinet Secretary. She spoke on our Newsgang broadcast on Thursday night last week on the capping and the regulations that affect by the ministry and the public participation exercise where Kenyans will be taking part to air their views.
On 13th of September, I spoke to you in the same studio, and you told me that there was a cap of 5,000 that was being introduced. When I spoke to you almost about 2 or so months later, you said there's no cap. What changed in between?
Some, and by the way, at some point I thought you were getting so personal on that matter. When I was here in September, we were talking about an amendment to NHIF Act. And in that amendment, our proposal was 5,000 shillings. Now, this is a new law. Remember, we had done amendments and gone up to the end. We were actually going to publish the amendments to NHIF Act. So we had proposed 2.75%. Remember, this had even been done previously, and there was a court case by Federation of Kenya, FKE. And that is what brought about the 2.75% with a cap of 5,000. We dropped the NHIF amendments. Now we have the Social Health Act, a new law. That is what changed.
Okay. Dr. Pukose, that's where the concern is, whether there will be a capping or whether there's not going to be a capping, because the lowest contribution will be 300 Kenya shillings. What will be the maximum in your view?
You know, at this stage, when it is still proposed regulations, everybody is entitled to propose. Yeah. In my position as the chair now of the committee, I would be biased to already take a position, because we would want to listen to as many Kenyans as possible to whether do we have capping or no capping. And I think, you know, I was talking to Dr. Davji, and I told him when it is when the current regulations is actually proposals. These are proposals that are going to be subjected to public participation. I know there is that fear that is telling me maybe we made some proposals in the bill and even no comma. It is not true. We changed many things. There were many things that we were able to change in the Act. And therefore, I don't think he should be worried that, you know, law is a living document. That will continue making and amending, and even after 6 months, once you've made a law, you can still come up with another proposal to make amendments to that law if we find that the law is not working the way it should be. So I don't think it is something that we should be worried about. I think the question will be, can we balance it? Can we have a capping? Because there are people who are proposing, can we have a capping? And we want to, even remember, we had an act, the Petroleum Act of 2017. In the Petroleum Act, we went to Turkana, and you'll find a villager who has even not gone to school was saying we want this thing called capping should be removed. And it depends on the circumstances, because for them it was a question of resources that were going to be allocated to the local, that's in terms of local content, to the local community. They were feeling if we put capping, then the local community was not going to benefit. And therefore, their proposal was remove capping. Now, in this case, people are feeling that if we don't remove capping, then maybe the figures will be very high. But let's listen to each other. And I think as a country, we must be able to listen to each other, reason together, and see how best we can be able to provide health care to everybody.
Okay, yes, Dr. Davji.
You know, the 2.75% of of gross salary is actually not even a statutory deduction. Is actually a tax. And when you put it on the gross, it means it doesn't make any sense. So ideally, for us, we see that 2.75% is an outright exploitation of the workers. And this is well embedded even in the report which you have seen from NHIF of the report of 2023, the financial report. You realize that NHIF utilization of the funds they had, it was only 87%. They even had extra 11 billion that was not utilized. So I don't know the rush of government to actually extract more funds from the salaried Kenyans and even from everybody, and then do not have mechanisms for their utilizations is actually just a cake. So in reality, we are totally saying that you cannot take 2.75% of the gross of workers.
But have we asked ourselves what is informing the government in terms of the 2.75%?
I think it is great
proposal, because what the government is saying, let's look at equity in terms of how much we contribute. My salary is more than 500,000. Somebody's health salary is around 20,000. Yeah, should we pay the same?
But
should I pay 1,700, and the person who is earning 20,000 pays the same amount? This is a debate that we should look at equity in terms of contributing to that.
Yeah.
And you know, like this is a social health insurance. I think that's the main point that we should be able to look at. We are looking at how do we match our resources together to make sure that all Kenyans are brought together. And that is why, like we are saying, those who are not employed, those who are contributing from their pocket, instead of paying 500, this person should be able to, the mamambogas, the boda, let this person pay 300 per month and also access the same services. But should I also say I should pay 300 because somebody else who is not earning is paying 300? It's not fair.
Okay, and then Dr. Pukose, what then informs the arrival at the 2.75%? Why not 6%? Why not 2%? And then the question of the unemployment question. If someone is unemployed already, where will that 300 Kenya shillings come from? What if he or she will not be in a position to even pay that 300 Kenya shillings?
As we speak today, we have Kenyans whom we call the indigents, whom government pays for their NHIF cover, and through assessment, and that is actually provided even in the current act, that government can use various modes to assess to find out that this is a person who can't pay, who is not able to pay. And this person now, the government pays for that person, the indigents. And we have many indigents who are being paid in this country. And what informs the decision of the 2.75%? I think this is an actual study that was done by the government, and they arrived at that figure. But I don't think it's a figure that is, I would say it is not cast in stone.
Yeah.
If people still feel that we can raise it to 6%, then maybe many Kenyans might get even more better services. Yeah,
but because why I raised that issue, Dr. Pukose, is that I know, yes, you are a professional doctor, and so as Dr. Davji and other professionals have the long-term perspective, which is futuristic, of reforming our healthcare system so that it works for every Kenyan. But the problem is that we have a manifesto, which is basically a political document where you seek the mandate of the people. And for example, the Kenya Kwanza administration in its manifesto had in June 2022 proposed a modest contribution capped at 3,000 Kenya shillings per household each month to fund the healthcare program. It never stated, for example, the 2.75%. The concern is the changing goalposts from what you promised and what you intend to deliver.
You know, somebody, if you get, depending on the opinions that people are giving you, and you have now professionals who are coming in and trying to, they are doing the actual studies and giving you a figure and telling you that this might not be able to work. If we put it at 2.75%, then that will give us equity. Yeah? if 2.75% will give us equity, then I think that that maybe the ministry could be able to explain how that actual study was carried out and how they arrived at the 2.75%.
Because I'm quoting directly from what the manifesto had stated, Dr. Pukose, and President Ruto then, who was the UDA presidential candidate, said, our preliminary analysis shows that a progressive contribution system can achieve 200 billion Kenya shillings requirement with contributions ranging from 300, which is now the base that the Act now talks about, and then 3,000 Kenya shillings per household. That's what you said.
Maybe I don't know how they arrive. The 300 per household is those who are not able to, those who are low income earners in the informal sector are the ones paying the 300. The 3,000 shillings, I think that was maybe an average. I don't know how they arrived it. I'm just giving my opinion. Maybe that was an average for those who are able to pay. That means those who are paying in the higher figures, the highest figure maybe 15,000, to the lowest figure who might be paying maybe another 2,000 or something like that. Maybe they did an average to arrive at that 3,000. Okay. I have no idea on how that was arrived at.
Okay. Dr. Brian Lishenga, the chairperson of the Rural Private Hospitals Association. Good morning, Daktari.
Morning.
Thanks for your time.
Thank you so much.
Appreciated to have you here. Happy New Year.
Happy New Year.
Is ending today. I'll come to you shortly. Right. Dr. Davjes, you had a point. Please proceed.
Yeah, I was just saying that the government is just driven by grades, and they need just to extract more from the workers. Because from the financial reports of NHIF of 2023, as I've told you, there was a surplus of 11 billion that was not utilized. We have here, the government is actually looking to collect more money without putting any plans to ensure that there's actual access to quality healthcare. If you look at the report, status report from the ministry in terms of the facilities across the entire country, that is both public and private, that can actually give somebody outpatient services in terms of the personnel, in terms of the equipment, and in terms of the infrastructure, there are only 7% of them. So what is the government doing about that? You realize that as much as they speak about the universal health care, they need to contribute more money. They need to there's no plans for that. This is just a plan to get to, I would say, to extract more from the people without actual plan to deliver, to give the care that are needed.
But Dr. Davji, as much as you are opposed to the government's pathway to this healthcare program under President William Ruto's government, for example, to just list the pillars, the 4 pillars, the human resource for health need to boost manpower, including unveiling of community health promoters. You were at Uhuru Park when the president did that. The integration of the health information management system to be augmented by digital health law, healthcare financing. The president assented the new bills into law that will succeed the present funding under NHIF Act. The health products and technologies, the pillar speaks to medical products, equipment and technologies. Isn't this, I mean, an aspiration towards a working healthcare system, and therefore unfair for you to play the men, in this case those who are in authority, and not the ball, which ought to be the case, and reading through all these, I mean, broken down procedures that the government is intent on rebooting our healthcare system?
I think it's more politics and more rhetoric than actual action. And why am I saying this? Because the government has been in office for more than 20 months. These promises were given in the manifesto. And if you look at the implementation, as we speak today, you go to any facility across the country, you will not get the services because there are no drugs in those facilities. And as of today, the counties, 47 of them, host KEMSA over 3 billion. So tell me, what is the priority of the government? In that case, we have the aspect of the human resource. There was a promise and a manifesto that they will employ 20,000 health workforce within 100 days of them being in the office. We are on 20 months, as I said. And you realize that even the employment of health workforce has reduced tremendously in over that period. In fact, we have more unemployed health workforce with the higher shortages in the hospital as never before. So that makes us see that the interest is more into the financial aspect than into the service delivery component. Because if you tell us, and I was saying that NHIF or Social Health Insurance Fund is more of a privatization to the NHIF, giving it just to the hands of a few individuals who will strongly benefit. Because with this Social Health Insurance Fund, as I said earlier, we have EduAfya, those high school children who could go to any facility and get care from From this month, they can't do that. How much was government investing on that? It was 4 billion, which government was investing from Ministry of Education was paying to NHIF, and these school-going children could access care everywhere. Now your parents have to look for money to make you access these particular services. We have the retirees in this country who are able to get care just by the aspect of the comprehensive insurance. That is gone. We have the civil servants, despite the deductions that are done in their pay slips, they can't access these cares anymore, which means that we have been having...
Also, if deducted... The assumption is that they can access healthcir. That's what Dr. said.
And I was telling Dr.
I actually want to disagree.
I was telling Dr. here that...
But Dr. Davji, to be also...
And I'm very honest with this.
Yeah, if deductions, we will all experience that deduction. And the express assumption is that we will access healthcare system. It's a guarantee.
It's assumption. It's not a guarantee. And why am I saying it's an assumption? Because
then why is my payslip deducted then without accessing healthcare? Does it make sense?
There's a problem that we see here. We have an NHIF Amendment 2022. It had a very critical component. There's what we call co-payment of healthcare. That's the NHIF, for example, is a baseline, and then you go to the hospital, depending on how much you're charged. For example, if you had a cesarean section in an hospital, and the hospital that you've gone to charges you 100,000, then the NHIF or social insurance pays 30,000. You have to pay the 70. You have to top up. In NHIF Amendment 2022, that was removed. It was that every person who was signing up a contract, every facility had a contract that whatever they will agree in terms of the costing of care, then will make sure that you go to the hospital and get the care. That has been removed with this shift. And then the shift has gone up to add that if you feel like that care is not enough, you need to get a private insurance. So that's why we're saying it's more over into process of privatization. The other aspect that is also very clear, all these persons that are benefiting from NHIF without thinking about their financial ability, the civil servants, the retirees, the school-going children, the Linda Mama. All this now will have to consider if you go to a facility and then the package is limited the way it is, you must look for ways to get more money, collect more money and get the service.
Yes, Dr. Leshenga, I'll come to Dr. Pukose. Dr. Leshenga, to get your comment here, and we seem to be having a debate on how to reform our healthcare system, though there are disagreements and there are well-documented differences because of the stakeholder and the different views that as a democracy we ought to have because it's healthy. But then how can we make the safe flight to the destination point of a healthcare coverage where Dr. Pukose, Dr. Davji, Dr. Leshenga, Ayub, and the millions of Kenyans watching this broadcast will access healthcare, get services, and do so without any hindrance and challenges that may forthcome from institutions that ought to provide these services?
So, thank you. So I will look at it from the point of view of the good, the bad, and the ugly. So what is good about, and I try to be fair in this, fair to Mheshimiwa Pukose and the government, is that the good is at the highest aspiration around these bills, which is to raise more money for healthcare. This, at this level, we can say that is very good because healthcare in Kenya is generally underfunded. And then secondly, we are happy with the buffer fund around emergency, chronic and critical diseases. As healthcare providers, this has been something that has been missing for a long time. And then thirdly, I would say the fact that now we have a dispute resolution tribunal between healthcare providers and the fund, the Social Health Authority, is a good thing. The representation of healthcare providers is also a good thing. So there are a couple of good aspirations within the bills that we have had. Having trying to take care of primary healthcare services is also a very high aspiration. However, while we are trying to do a lot of good things, the top one being raising enough money to take care of every Kenyan, because healthcare is underfunded. If you look at what we think should be the annual expenditure on healthcare, we think that the country should be spending something like 400 billion shillings.
In the current financial year, 141.
NHIF was at best doing 80 billion shillings. 81 billion shillings. So if we do manage to get to a point where we are raising 200 billion by a combination of payments and, contributions and parliamentary appropriation, that is a good thing. However, we have consistently asked, what is it that the bills are doing now that could not have been done through incremental amendments to the NHIF Act. You see, so our concern is, while the aspiration is good, nothing that we are trying to achieve today could not have been done by bringing an amendment to Parliament for Parliament to take care of the amendment and do it. So as a result of this, we have a ministry that is trying to do too much within a very little period of time. Let me give you an example. So we have something called a transition period that is supposed to be 12 months. Do you know what they are supposed to do within 12 months? Just give you an example. Within 12 months, they are supposed to conduct a thorough inventory of all the assets of NHIF, of all the liabilities of NHIF, and then hire people, new staff, and then for staff who decide to go elsewhere, who are in NHIF now, they are supposed to process their terminal leaves and also redeploy them. Within 12 months, they are supposed to conduct nationwide proxy means testing for everyone who is above the age of 25. Essentially, and you know, this is some of the things we have been very concerned about. So let me give you an example. If my wife is 25 years old, she's unemployed, she's a housewife, let's say. According to what we have put in the Act, she is by definition a household. You know, because there is no difference between what we call a household and a contributor. The Act says a contributor is also a household. So you could have a situation where in Kenya, you have a family, which is a social unit. But within that social unit, what we have done in the Act is to make sure that that social unit now has 2 households. Now, we do proxy means testing across the entire country for anyone who is 25 years and above who is not in college. And we have to do that within the next, 6 months, 12 months. We also have to do procure and deploy a centralized digital system. And for me, where I sit as the national chairman for rural private hospitals, this is one of the things we have complained about called wastage. You see, NHIF for the last 3-4 years has spent 3 billion shillings to procure digital platforms. Now we have put it in the Act that we must procure one. This, for me, is crazy. And let me give you an example. If you look at what we could have done, look at Murang'a County, for example, where they have the governor had this thing called Kang'ata Care. Kang'ata Care has been able to cover for 40,000 households at a cost of only 320 million shillings per year. Can you imagine what 3 billion shillings on a digital platform would be able to do? And we do not need a law to do that. We just need to get our acts together.
Okay, so coming to you, we'll also get the soundbite here of Susan Nakhumicha, the CS on NHIF. Dr. Pukose, you only had a point, please.
Thank you. First, I wanted to say I disagreed with my colleague here, Dr. Devji, on many issues. You know, when you are him, he's a healthcare provider and a representative of the Union of Healthcare Providers.
Yes.
Now, when the government has put in place structures, he's saying that the government has been there for the last 20 months. It's true. But within that 20 months, the government is trying to put up structures to make sure that everything runs accordingly. That him is able to provide when people come to the hospital, he's able to treat them and take care of them. Now, I wanted him to be able to look at, to critique it in terms of what is it that, because, you know, we are talking about both the national government and the county government. Their roles, this government, since it came into place, it is paid county governments in time. All county governments have been paid in time. Their money has been released in time. What is it that the county governments are not be able to, the healthcare workers in the counties are not able to do that they should have been able to do with the government in place? One of the things that we've done is to bring up support to them by having the primary healthcare workers or the promoters.
Level 1 to 3.
Level 1 to 3. Now, at his level, at level 4, level 5, level 6, it needs to tell us what is, you know, like one of the things, it is true that the UDA in our manifesto, we said we will employ healthcare workers. But in terms of those healthcare workers, already, even these 100,000, they are healthcare workers. We can't say they are not healthcare workers. Although it is in the definition of the workers, they are not part of it. But in terms of doctors, nurses at the various referral facilities, he's supposed to have been able to confront me now and tell me that in the national referral facilities, this is the number of doctors, nurses that have been employed, and this is the deficit that is there. Then we're able to now pursue it with the government to see how can we be able to take care of that gap.
But as a professional, Dr. Pokose, you do also appreciate the fact that we have doctors shortage in this country.
I know that.
Yeah.
And in fact, in one of the things, even in this year's budget, we had an issue which was raised by the union themselves and the Kenya Medical Association about us having Cuban doctors working in this country. And majority, we know that these are services that can be provided by our own doctors. And in the current budget, in the current budget, we've actually, in the supplementary, I think we removed any remaining amount for Cuban doctors, and I think their contract ended in December, and they should be able to go, so that that deficit can be able to be taken care of by our own local doctors. And we appreciate that. That is things that we are aware of. We know that our training institutions have produced now many doctors, many nurses, many clinical officers who are outside there and unemployed. But remember also that our president, with the government of the Saudi Arabia, has created that we can be able to send into Saudi Arabia 2,500 nurses.
And we have a shortage here back at home.
We have a shortage, but we also have excess nurses that are outside there and unemployed.
So
so we must be able to balance. Can we be able to look for them somewhere where they can be employed? And then now we need to debate. If we have money, then we should be able to also employ in our various hospitals.
But what's the point of shipping them out when they are required back at home?
Priority.
Shipping them out,
Is the priority the Saudi people or the Kenyan people?
You have many nurses who have graduated. Yeah, we actually have excess nurses who have graduated. And if you remember, we've been sending nurses have been going to Canada, they've been going to Australia, they've been going to UK.
Yeah.
We've been sending nurses to Namibia. It didn't start with this government. We've been sending nurses and even doctors to South Africa. So I think it's a question of where can we, these are people who have graduated. We might not be having money now to employ them now. Yeah. So that when we don't have money to employ them, do we allow them to just stay at home and do nothing? When other countries, we can be able to export them and they work there and even send back money that we can employ others here.
What happens to then institutions and people who require them here back at home? What does it tell us about generally our policy system and how we administer ourselves as a country? And this is now the audit question of since independence, how we have been unable to have a properly functioning healthcare system. Yes, they get employed in Saudi Arabia, they send money back at home.
And we employ other nurses to work for us.
Then what does it say about the government that you can't employ your own people?
You know, resources are not, they are scarce. Money is scarce. Money is not enough.
Yeah, thank you.
Yeah? The government might want to employ, but if you don't have money, do you go ahead and employ?
Okay. Let's hear from the health CS, Susan Nakhumicha, on what she said about NHIF. This is still, or to just put it on, that this is, or these soundbites are from our News Gang broadcast on Thursday last week, hosted by Sam Gituku, Yvonne Okwara, and Linus Kaikai, our executive editorial director. And here is what she said on NHIF.
I've seen most of the systems in this country, there are always challenges, even when it comes to elections, despite a lot of piloting. Don't you want to spend some time to see how the system works, the piloting itself, because it's an entire phase to roll out a system?
And why the rush in the first place?
We are not rushing. We want to provide care for Kenyans. So there's no rush in that. As I have told you, I may be fine right now. I do not know about tomorrow. I may be sick. I will need care. So we are working efficiently. I think one thing that government, that Kenyans now must appreciate that is that this government is efficient. That must be appreciated.
Okay.
You know, we are used to that government projects must take forever. Number two, would you fear to set up a system because it will fail?
No.
It doesn't make sense. So set up the system. Whatever challenges crop up, see how you mitigate, see how you take care of them. And we have a risk plan for all this that we are planning to do, so that if anything arises, then we are able to mitigate. But we are not going to sit back and say, since systems fail, so we are not going to have a system. That will be responsible of us.
Okay. And that's LCS. Yes, please, Dr. Davji.
I just wanted to say that there's this elucidation of primary health care by the government and the team that makes national government really feel like that is the cornerstone of healthcare in the country. And if you look into it, it's actually not working. It's just a talk. Why am I saying this? Because Mheshimiwa here is saying that we need to look at whose role is it for employment of health workforce, whose role is it to ensure that there's functionality in the counties and in the hospitals. But we are seeing national government, we are seeing the assembly very well interested in this aspect of primary health care, which actually is a function of the counties. Why is it that if it comes to that, the national is interested and they talk about the UHC, but when it comes to the delivery of care to the people, which actually need a functional human resource, need employment of health workforce, nurses, doctors, and other healthcare workers, then that now is shelved out. Say that we have to discuss that with the counties. Why am I saying this, Abdi? That in the country as it is now, we need about 200,000 nurses to actually make these hospitals operational as I suspected. We need 50,000 doctors employed in the hospitals. Yet, in that same scenario, we have 4,500 not employed. We have about 10,000 nurses not employed. We have all this health workforce was employed, and the country is saying, no, you can export them out. The South Africa is talked about. I participated in a demonstration in South Africa when only 250 doctors, last year, January, were not employed. And I can tell you, every doctor that graduates in South Africa, despite them producing twice the number of Kenyans are employed. So there's no any way we will be priding ourselves to again export the doctors to South Africa, to other countries, when ourselves in our hospitals, as at now, we don't have that workforce. We have to demonstrate for the ministry to post interns. So this talk, or this ulubalu, these thoughts about UHC that are building, that policies, that laws will make it able to access the care is just a dream that the government and political leaders have. We have to actually have a plan to employ health workforce, a plan to ensure there are drugs in those hospitals, before we actually see to it that we have universal health care. Yes. Otherwise, it will remain a dream.
Dr.
Lishan.
Let me just ask this, Ayub. What is it, and just back to Mheshimiwa Pukose's issue of unemployment. So what is it in the current 4 health bills that even attempts to address the issue of healthcare and employment? Yeah. And I will tell you that we have to get away from sound bites and politicization of issues, because nothing in the health bills, and I'm saying this with due respect to those, in the acts, with due respect to the drafters, nothing in the acts, the 4 of them, addresses the issue of healthcare and employment. Let me give you my diagnosis as a doctor of what is the problem, and we keep going back to the issue of primary healthcare. Primary healthcare in this country, and this is where we might differ with Davji, because my background is, primary healthcare, is important, but is extremely underfunded. In this sense, we want to deliver primary healthcare at level 2, level 3, level 4 facilities. But what is the problem? What is really ailing level 2, level 3, level 4 hospitals and government county hospitals for that? I will tell you what is ailing them. And the reason why they cannot employ more nurses, they cannot employ more clinical officers, more doctors, they are grossly underfunded. And they are grossly underfunded. And the reason why they are underfunded, and the things which we should tackle without going into too many stories, is, for instance, county hospitals. And you hear the minister talking every now and then about private hospitals being paid more than public hospitals. And so the Act doesn't address that. But public hospitals, Mheshimiwa Pukose, are extremely poor at presenting claims to any fund. And we will not cure this by what we have done. So we have structural issues that are very easy to handle. Ask me, why is my level 3 hospital, which is a government hospital, seeing clients working every day, but when you look at their books of accounts, there's no money? The reason why this is happening is really nobody at that facility has the final responsibility to make sure that they present a proper claim to the fund.
Okay. And I want to ask you this because an internal audit by the Ministry of Health investigating the activities of hospitals between July 2022 and June 2023, 1 year, found that 171 million Kenya shillings was lost in the illicit scheme. The Ministry of Health estimates that more than 20 billion could have been lost during the stated period, meaning the country bled billions over the years. The figure is as a result of an extrapolation with the assumption that 40% of the country's more than 8,800 healthcare facilities could be engaging in fraud. This is what we can't run away from. And private hospitals have been fingered in this report. So how can we address this? Because I'm sure it's a concern which as well Dr. Pokose and any Kenyan is concerned about. Because what the Kenyan people want, and you professionals, you'll agree with me, is a working healthcare system where one can access healthcare. There's fraud. You have reservations. The government has its grand plan to proceed to achieve the universal healthcare status. I mean, where's the point of convergence and how do we address graft in all this debate?
So, Abdikader, if I can answer you, if you want to kill a dog, the first thing you do is you give it a bad name. You say the dog has rabies. You know, this dog has been biting children in the neighborhood. And from where I stand, I admit that graft is probably a problem. But I want to pose a challenge to those statements that you have made. What are the actual NHIF numbers for graft? And I have the data from where I sit. Today, the number of claims which are under investigation within NHIF represent only 0.5% of all claims submitted. 0.5%, Abdikadir. So, in other words, if you log into the NHIF platform today, 99.5% of claims submitted by their own account are absolutely above board. So why is it then that we are hearing a lot of conversation around graft? I will tell you what is happening. And back to what the Honorable Cabinet Secretary was saying. She said that up to 20 billion shillings could have been lost. And if you go through that statement, you will see that she said something like about 60% of healthcare providers were engaged in graft. The facility census report that the minister launched in December last year showed that we have about 5,800 healthcare facilities in Kenya under NHIF. If you say that 60% of them were involved in graft, it will say like 3,400 hospitals are stealing money from NHIF. But is that the private sector? The same report said that we only have 1,900 private sector hospitals. So, in other words, what they are really saying about the graft issue is all private hospitals in Kenya are stealing money, 1,900, and then another 1,000 public hospitals are also stealing money. Why am I saying this? We are politicizing the issue of graft because we have to find a reason to say that the reforms we are doing are going to cure the problem. If there is graft, and I saw that, these 8 or 9 facilities were appearing before Parliament. This is what we want to see as private sector players. We want to see prosecutions. We want to see people being jailed for actually stealing patients' money. But there is no one-sided graft, Abdikadir. It's no way a hospital can steal money from NHIF. There is people inside NHIF that also approve these fraudulent claims. Have we seen any prosecutions inside NHIF? Have we seen anybody being held to account? Can you imagine if you were the CEO of a government agency and during your time in office, 20 billion shillings got lost from that office? Shouldn't we be going back and saying, who was CEO of NHIF when 20 billion got lost? Who was Minister for Health?
The question of accountability.
Accountability.
Okay. On that note, let me go to Dr. Pokose, because Daktari, the minister, talked about NHIF and the foreseeable problems which she said will be handled as we go by. But how do you give the Kenyan people the degree of assurances and guarantees that this will be substantively addressed? Because we talk about private hospitals, we talk about public hospitals and NHIF, and the common denominator and the theme is that there is graft and the admission bed by the government through the minister. I mean, how can that be addressed even as we debate about how to reform our healthcare system?
Thank you. First, I want to agree with him, Daktari, that primary health care and is actually a key factor in terms of for us to manage our healthcare system in the country. It is not just by people being treated. We can also prevent diseases. And if we put more money in the prevention, then we will save even more money in terms of treatment. The other issue which I want to say is that healthcare is underfunded. In the Abuja Declaration, most of our countries pledged to raise the money for healthcare into 15%. Yeah. Many countries even us as a country, we've not achieved that. I think we are doing around 7%. So we are doing 7%. And in that case, I think if we have to get our healthcare right, then we must allocate more resources to our healthcare. Absolutely. The other issue which I want to say is that when you look at I want to also agree with him in terms of claims. When you look at our public facilities, one, they are poorly managed. Two, nobody takes responsibility. You will find that, and then the level of even cleanliness in the hospitals is very low. And somebody feels even you become more sicker going into government facilities. And I think those are issues, my colleague here, Dr. Devji, you need to be addressing them. Yeah, that why should people be going into, why would you have a private facility there and you have a government facility there? People would prefer to go to the private because you'll be attended quickly. You will get all the medicines you want, you will get clean services, and people will treat you in a humane way. We need first to change the attitude within our government institutions. People who are working in government institutions should take it that it is a responsibility, and it's even a honor to treat somebody when somebody walks into the hospital. You should be able to talk to this person in a way that the person feels I'm really being given the attention that is due. So we must clean up, we must make sure that our government facilities are clean. We must make sure we have medications. We have to make sure that the services are there. And more often you'll find that you go to government hospitals. I read an article yesterday in one of I think it was in the X forum, where in Chepkoria, people close offices and they go to their farms. That should not happen in this country. Okay. So I want to now come to the issue about the fraud, which my committee is actually investigating. And what we've done is we did not go only to the 8 facilities that have been mentioned. We've decided to widen our scope to look at even facilities that are making big claims. What is it that they are doing right so that they are able to make big claims? Facilities that have been mentioned and they are not doing things in a regular way. I don't want to mention, but we went to a facility in Isli on Monday. And you reach in that facility, people run away and they close the facility. Then you wonder, what is it that they are hiding? Because if you have nothing to hide, then you should be able to take us through. We went to another facility, which was in Madare, in Isli towards Madare side. People are living on top of their house. They are in their apartments upstairs. The hospital is in between there. And where the hospital is located, you wonder who registered this facility. They have no even theater facilities. Yet they claim they've been making claim. They have a claim of 400 million. And you look at, as a doctor, you have no theater. You have no anything that will that you can build to that level. How are you making that? Okay. So in this claim, for that person to make that claim, then there must be collusion between the NHIF staff, the doctor, and even at the headquarters, the claims management. Okay. Well, and therefore, when we make our report, because today we're visiting Nyahururu, tomorrow, and then Nakuru and Elbagon, tomorrow we'll be in Eldoret, and another team will be in Embu and Meru. Then next week we'll also be in Garissa and other places. When we make our report, I don't think we'll leave anybody out. If you are culpable, then you should be prosecuted.
Thank you. Amen. Looking forward to that, because I attended the first session of your committee looking into the allegations of fraud. Dr. Davji, because this is a responsibility and answer-seeking show here on Daybreak, who registers hospital facilities?
The Kenya Medical Practitioners and Dentists Council.
And that's a very critical...
The critical component. In the operation.
And how comes then, is it not also on your end as the Union Secretary General, and of course alongside your colleagues, to also ask the questions as to how such a facility mentioned by the chairperson of Health Committee ended up being registered, making claims for services they cannot provide, yet, and it's in a residential centre, sandwiched between second floor and third floor, for example, and it's disturbing, is it?
We've actually brought this matter strongly to the council, I mean to the ministry, whereby we are saying that when a facility is accredited as a level 4, a level 3 or a level 5, it should not just be a structure. It should be followed up with the services that it needs to offer, the human personnel, the equipments, and the infrastructure that is ours. And this is not limited to just the private facilities. It's also in the public facilities, because we have seen situations whereby a politician just wakes up and say, this hospital is a level 5. But then it doesn't offer the services that ought to be offered by level 5. We saw that in Thika level 5. We realized that in Homa Bay. We've seen those happening.
Just with due respect to politicians, I don't think politicians...
the politicians actually play a critical role in
now
this.
Classifying this as level 5.
Because, you know why I'm saying...
the ministry or
you know why I'm saying
the
this?
ministry,
Because
can you upgrade this facility to level 5?
The influence and the dictates. And sometimes they make even the operations...
That's not how it should happen.
They actually make the operations of KMPDC difficult. The political interferences actually make those facilities to exist. Because you try to weed them out, the next day you get a call from a politician. That's the complaints that we received from KMPDC. So if the political leaders, the ministry, and everybody is supposed to do their role as they ought to be, then I think there will be a much change in that. The other thing I wanted to say is that, you know, Abdi, when you see a snake in your house and you bring the whole house down, you must be either owning the contractor or you're the contractor. And that's what we are seeing with this aspect of NHIF and the alleged corruptions, to the point that 171 million was being extrapolated to 20 billion, when in that end of financial year, NHIF had collected 81 billion and utilized 70, meaning that it is out of this 70, 20 billion was out for corruption. So it leaves a lot to desire. And we have known, it is evident that the interferences in NHIF, in KEMSA, and all these scandals and corruptions that are done and they're instigated and planned by people at the ministry. So if they're left to run independently with structures, it will be more beneficial. Yeah. Again, another thing is that it is not a matter of helplessness by the ministry to just announce figures in corruptions and not bring anyone to book. It means there's a narrative being brought. Ideally, as Olisanga said, when there's a purported corruption, there's a purported pilferage of funds, people need to be brought to book from both the ministry, if there are people there, from NHIF, and even from the facilities. And this was coming out very strongly because of the comprehensive cover, to which even my colleague has one told me that there's a wastage in the comprehensive cover. That's why they've removed it for both the EduAfya, for both the Linda Mama, for the parastatals. But when you look at the figures...
Actually, it's not wastage, it's an abuse.
That's the word is used. Okay. But when you look at the figures within the facilities, you realize that the utilization of the funds was only at 7%. And there's nobody who has been brought to book that was abusing this fund. Okay. So you cannot say today that...
In our report, we are going to bring out, especially in EduAfya, where we even have facilities that have returned money.
Yeah.
Money has been recovered from those facilities.
But Abdi, you cannot deny school-going children, civil servants, and people's services because there's somebody who is corrupt somewhere. You need to deal with the person who is corrupt.
Thank you. Dr. Leshanga, I'll come to you. Let's hear one final time from the Cabinet Secretary, Susan Nakhumicha, on premiums and how she explained that to happen.
We have developed a tool a means testing tool to be able to analyze the incomes, to determine estimates of incomes, and that is what we are going to rely on. Where like education, Ministry of Education, they have used a means testing to determine the levels of bursaries that they are going to give students. So it is not going to be unique to us. We shall use the same tool, maybe an improved version of it, so that we are able to determine the incomes. But remember, we have, this is our one government. We have Hustler Fund. There are people who have onboarded on Hustler Fund. And for Hustler Fund to determine how much you can borrow, it is based on your income. 21 million Kenyans. I'm told actually 23 million Kenyans by now are on Hustler Fund. So, and actually even in SHA, we want to also leverage on that. That should you not be able to pay for your SHA right away, you can borrow money from Hustler Fund and pay for your premiums. Okay.
Okay, I'll come to you, Honorable Pukose, on that. But first, please, as we wind up.
Yeah, so I'll just pick up quickly from where we were talking about Eduafia. And I want to appeal to Honorable Pukose to be very fair when they are going out. When he says there are facilities which have returned money, I want him to, as a medic, I want him to go deeper. Because the reason why they returned money is the initial Eduafia contract was telling providers you will be paid 1,500 shillings per patient, per visit. But then what happened later was they reclassified some facilities and said if you are level 3 and below, you will receive 1,000. So these facilities which had previously been paid 1,500, all of a sudden you are being told you have made an overpayment, you have been receiving an overpayment of 500 per visit. So we have quite a number of facilities which are being suspended, not because they were fraudulent, but because NHIF recategorized payment. Let me just say that. But I want to come to something the Minister is saying about the means testing, proxy means testing. For me, my biggest fear here is for you in Kenya to get jobless under these bills.
Yes.
If you get jobless under these bills, it's going to be... And I'm speaking here and hoping that even our legislators are listening. It's going to be a most difficult part. Number one, the Act says there shall be periodic means testing. Now, let me ask you, Abdi, if you lose job, like I lose a job today, and maybe my job, I was being paid 100,000, let's say, for a good figure for calculation. Based on the premium, the 2.75%, my contribution was 27.50 per month. Now I am jobless. So all of a sudden, I have no income. I am back at home, but I still need healthcare. Maybe I have a 2-year-old in the house, I still need healthcare. Ideally, because I have no income, what should happen is you should recalibrate my premium. But the system already has registered me as somebody who pays 27.50, isn't it? Now I am defaulting because I don't have a job. But how will the fund, the authority, determine what is my new rate? They must do a proxy means testing. Proxy means testing, according to the Act, is being done by the Ministry for Social Protection, the Bureau of Statistics, and Ministry of Health, and it is not a daily thing. So all these guys who are going to become jobless is going to be, if you lose a job, it is going to be very difficult with the current regime that we are creating for you to transition from the premium that you are paying to the new premium that you can afford. Number two, on the issue of Cabinet Secretary is talking about premium financing through, for example, Hustler Fund.
Yeah.
It's very innovative, but there is a danger here that I need to point out. The danger I need to point out, Mheshimiwa Pukose, is this. We have a risk of having what we call a double whammy, where something becomes a double jinx. So let's say, Abdi, that I am using a Hustler Fund to pay for my premiums. And for some reason, my biashara, my side hustle, doesn't do well. Because remember, when we are talking about premium financing, it is the individual who will be left with the baby, that the baby being servicing the loan.
Okay.
So say I cannot pay it. So all of a sudden, at the end of the financial year, I have two problems. Yeah. The first problem I have is Hustler Fund is on me. I have not paid the premium, what they expected. The fund, the authority is on me. I need to renew. Double whammy.
Okay.
And again on that.
Yes, Dr. Pukose, we are out of time. Allow me to get in, Dr. Pukose. In relation to what Waziri Nakhumicha had said, so explain to us the benefit of the package and the cost?
The benefit of which package?
For example, say, if you are to access healthcare.
First, I want to agree with what he has suggested. And I think that is something that can be addressed through regulations. You remember you appeared before our committee during public participation. And this issue about the dispute tribunal, is you guys, you gave us a lot of input into that, and we captured it. I just wanted Dafty to know that, it's not always that it's cast in, it's not always that everything is cast in stone, that we refuse to accept any good ideas. So the ideas which he's raising are actually good ideas. I've listened very carefully.
Thank you.
And I think when we'd be in the process of doing these regulations, we should be able to look at how that can be resolved. The benefit package that you know, these are social health insurance for everybody, meaning that it is a question of, you know, the UDA government under President Ruto promised Kenyans that we want you to our country to reach a stage where you walk into the hospital, you get treated, and you go home because as we stand today, many people lose property. You sell your land. You have even bodies that are being detained in the hospitals because of huge hospital bills. So we want to get out of that cycle, that anybody can go to the hospital, you get treated without necessarily your relatives sitting down. Even us as members of parliament, every day you are called, we go for our rambles. You find our constituents are selling land, they are selling property so that one of them can be treated. So I think that is actually what we are trying to work on, to make sure that every Kenyan can access quality, affordable, and accessible health care.
Thank you.
Without at the cheapest cost possible.
Thank you. Thank you. Your time is all appreciated. 30 seconds. Dr.
I just want to address this issue that was brought about regarding the public facilities being dysfunctional. And I must say that as a member of parliament, chair of health committee, I went to the government. None of them actually seek services in these public facilities. So in essence,
I offer services in public.
So
and
you see the dysfunction. You see the dysfunctionality.
Pro bono.
You see the dysfunctionality in them. So the reality that is there, and even as I speak today, the resident of Homa Bay County can't get care because doctors have been on strike there for the last 2 weeks. So what I'm trying to say is that there's no way when political leaders like my brother here and all the state officers have hefty private insurances that they can seek care anywhere, like the rest of them, like even the ministers.
But then, including yourself, Michael.
But then they come on this other side.
That category.
They come on this side and say we have a social health insurance fund that will make sure you access the care. Yet it's a baseline. And again, the facilities that are going to access the care, there are no health workforce that is guaranteed.
Thank you.
So they have to really reprioritize healthcare and change it from rhetorics to actual action.
Thank you. Your time is all appreciated. Because we're out of time, Dr. Brian Lishenga is the chairperson of the Rural Private Hospitals Association. Thank you, Dr. for your time. We hope to have you again alongside Dr. Davji Atela, the Secretary General of the Kenya Medical Practitioners and Dentists Union, and also Dr. Robert Pukose, a medical professional and practitioner, and the chairperson of the National Assembly's Health Committee, as well as the lawmaker representing Endebess constituency. Your time is all appreciated, gentlemen. And at the best interest of time, will not be able to sample your feedback, but the broadcast continues after this short commercial break here on Citizen Television.